Okay, perfect. All right, guys. Well, welcome to a very special evening with Dr. David Charash. Dr. Charash is a very well-versed and experienced medical physician. He is also a multi-time Boston Sea Rovers presenter, as well as presenter in multiple other venues around the country, different groups, commercial applications, government, special military, and all sorts. Tonight's presentation is going to be based on diving medical fitness, especially in the new era of COVID-19 and the new RSTC medical standards. A few things to bear in mind before we crack on. We will have the chat open. If you could please post any questions that you have in the chat. We are also recording this evening's event. So if you do not wish to be seen or heard on that recording, it is going to be shared on YouTube and other multiple media channels. So I would highly recommend muting and shutting off your cameras if that's something that you don't want publicly available. With that being said, I hope you guys are excited as I am for this evening's presentation. And without further ado, I will hand you over to Dr. David Charash.
Well, thanks, Nick, and I appreciate your partnering with me to allow me to speak to your group, and welcome everyone and good evening. I want to let you know that my plan is to have a presentation, and you're welcome to put questions in the chat. But at the end of this, I typically like to open up the mics and we can have an open discussion regarding this or any other topic related to dive medicine, dive fitness at the end. And so with that in mind, I want to give you a little bit of introduction to who I am and what I do. I am a physician, board certified in emergency medicine and undersea and hyperbaric medicine, and have been involved in the hyperbaric diving community since the early 90s. I trained in hyperbaric medicine in Michigan and have been active as a physician in hospital wound care centers with hyperbaric, have been trained by NOAA as a dive medicine physician, and have been a instructor, teacher, an educator in dive medicine, dive physics, and dive physiology. And I've had the honor of teaching at the Naval Undersea Medical Institute at Groton. I also have been giving lectures at the Coast Guard Academy to the cadets in their dive program. And I lecture nationally and internationally on dive medicine, dive safety, dive technology. And I have a company called Dive Medicine and Hyperbaric Consultants. I'm stationed out in Western Connecticut and basically offer education, training, teaching, and medical services to the diving and undersea community. So with that as a long-winded introduction, what I'm going to talk to you tonight about are the new World Recreational Scuba Training Council fitness guidelines. And why that's so important is because it recently has been updated, and many recreational technical divers are unaware that these guidelines are new or have changed. And they're so updated that they actually reflect the issues of COVID-19. So given that we all have our concerns going forward in our diving about what are those issues related to COVID-19 and how it could affect me and my fellow divers, that we're going to kind of piggyback that discussion with the update in the Recreational Scuba Training Council fitness guidelines with the current knowledge and recommendations and guidance that I can give you and impart to you diving in the COVID-19 era. So when we talk about diving, we have to always think about the risk in diving. And there are 6 basic risks as I view it, and I think we all view the same way. There's a risk of barotrauma, the risk of decompression illness, the risk of arterial gas embolism, panic, drowning, and traumatic event. Now, when we talk about fitness to dive, there are actually 6 components to fitness to dive. There's the physical skill, the knowledge you need to acquire and maintain and develop to maintain that degree of fitness, a degree of physical fitness. And that physical fitness is dependent on the kind of diving that you do. Nutrition is a component of being physically fit. The psychological fitness and then the medical fitness. And today's discussion, for the most part, will focus on the medical fitness as we look at the fitness to dive. But when asking the question, am I fit to dive? You have to really look at what kind of diver are you? Are you a recreational diver or a technical diver, public safety diver, scientific, commercial, military diver? Each of these different classification of divers have a different work requirement. So the physical fitness per se for a recreational diver is clearly different than a military diver. And a technical diver who will be diving in caverns with 200-foot penetrations, being underwater with long deco times, certainly has to have a different set of physical skill, mental skill, and psychological fitness than a recreational diver diving in warm water in 30 or 40 feet with low current and great visibility. So when we look at divers then, we see that divers come in all shapes and sizes, all age groups, and all degrees of fitness. So the first thing that we have to understand as a key concept is that diving can lead to the deterioration of your medical condition, and that medical condition can present an increased risk for diving injury to both the individual and your diving partner. And this can lead to issues related to loss of life, limb, or property. And when you're on a, for example, public safety dive team, that risk is imparted into the community. And if you're a commercial diver, for example, that risk is imparted into the world. If we have a catastrophic event on an oil platform, for example, and you had a medical emergency at 60 feet while working with a torch and caused an explosion on an oil rig, for example, the loss of life and limb and property is not just an individual concept, but is something that could affect, world, the world economy, for example. And when we think about what is diving physiology, it is encountering problems of diving medicine that relate to the behavior of the gas laws. And it's the effect of the gas volume in response to pressure changes in the solubility of the gases and liquids, which are the main issues resulting in injury or illness. So it's really quite simple, right? It's understanding the gas laws, the principles, and how it could affect me as the diver based on my own personal physical characteristics or medical physiology or genetic predispositions or medical history. And when we look at diving fatalities, and none of us want to be a fatality. That's not a statistic I want to be, nor do I want any one of my diving buddies or anyone in my diving party to be a statistic of a diving fatality. But Divers Alert Network looked at a series of diving fatalities, and there was one underlying theme that was uniform amongst diving fatalities. High up on the list of causes for diving fatalities was a pre-existing medical disease or pathology in the diver. These pre-existing conditions were either known or unknown. So I may be diving with an undiagnosed hypertension or enlarged heart. And when I dive, those stresses that cause physiologic changes, which could cause a catastrophic event, a triggering event. My heart can go into a rapid heart rate, for example, that will cause me to panic, and I may make a rapid ascent to the top. I may ultimately have an arterial gas embolism because I breath held on ascent, but the trigger event was my underlying cardiac or my pre-existing medical condition. Now, of course, diving fatalities also occur because of procedural errors and poor buoyancy control and environmental issues and equipment problems, but the majority, the highest percentage, the highest concentration is pre-existing disease. And when we look at diving fatalities, and I don't want to be somber, or this should be an upbeat discussion, but we'll put the pendulum swinging to the far left, and we'll put diving fatalities off to the side, and we'll learn about everything we can do to swing that pendulum to the far right, where we have a successful and enjoyable diving venture. Diving fatalities, when we think about issues related to physical fitness and heart disease and underlying comorbid illnesses, other medical conditions that could trigger these events, age in and of itself is not a risk factor for a diving fatality. it is the underlying medical issues that that older person has. And what I mean by that is, when I was in high school, and I won't tell you what year that was, the average age of recreational divers in the United States were about 22 years old. The average age of a recreational diver in 2020, 2021 is in the 40s. And you have to ask yourself, well, why is that? Well, in 2008, when the markets crashed and both parents were unemployed, right? And people really were in bad straits, the last thing they were thinking about was diving. Children had to leave school. When you graduated college as a child after this period of time when your parents both were unemployed and not able to help you with some of your college tuition, and you had these exorbitant bills, you ended up living in your parents' basement, right? And as you were doing that, trying to get a job because employment was really challenging to get at the time, the last thing on your mind as an undergraduate, recent graduate, was to go scuba diving. So now that I'm 45, I'm finally out of my parents' house, I'm finally on my own, I'm now going to celebrate by becoming a recreational scuba diver. The problem is that as I've aged, I've also become somewhat physically deconditioned, and I may have acquired things like hypertension, diabetes, high cholesterol, which is a risk factor for a catastrophic event if it's not addressed and if you're not really medically or physically fit to dive. So age in itself is not a risk factor, it's the baggage that comes along with it, those medical conditions. And when we think about cardiac disease, if we had to pick one disease entity, there's a high preponderance of cardiac events in diving fatalities. In studies in divers aged greater than 50 years old, 28 to 30% of them had a cardiac issue that was a triggering event that led to their fatality while diving. So that's roughly 1 in 3 diving fatalities had either known or unknown cardiac disease as a triggering event that may have led to a catastrophic rapid ascent or loss of buoyancy or panicking. So as we get older, then our risk factors, forget diving, for heart disease go up. Unless we address those, we potentially are setting ourselves up for a statistic that we don't want to be. So historically, when we become a recreational scuba diver, we have to get a fitness form that we filled out, which was a Recreational Scuba Training Council form that was adopted through all the training agencies, essentially internationally. And that hadn't been updated since the 80s, 1980s. The panel of experts that put that guideline together were actually lawyers and divers and physicians. And that was fraught with some issues internationally because it hadn't been reevaluated, and there were recommendations and guidelines that seemed to really not be appropriate for the recreational diving community. So in the past 2 years, an international consortium of experts in dive medicine, dive physiology, dive safety got together, and they put together the most recent World Recreational Scuba Training Council medical fitness guidelines, which were updated and adopted through all training agencies, both nationally and internationally, Divers Alert Network, and also the Undersea Hyperbaric Medicine Society as of July 1 of this year. These are guidelines that are determined and intended to be useful to you, the diver, and useful to the physician who has to fill these out. The goal globally is to reduce the number of preventable injuries and deaths. And this fitness guideline has international acceptance, and it was a collaboration of international experts throughout the entire world of diving. So I want to go in some detail, and I think it's important to understand some of this detail because some of you are recreational divers and technical divers. You still follow the same standard for medical fitness, but some of you may be public safety divers or scientific divers or military divers or commercial divers. So the standard, that is the guidelines that we follow for recreational scuba diving, or any of these diving classifications are either proscriptive or descriptive in nature. And what that means is if you're proscriptive, it's a checklist, it's very exclusive, it's based on concerns for liability, versus a descriptive standard is one in which the guideline is intended to be very inclusive and is designed to educate the diver to protect him or herself. And when we look at then the standards for medical fitness for recreational scuba divers, we can see that that medical evaluation is a descriptive in nature standard. So it's intended to be very inclusive. It's not intended to be exclusive. Whereas a commercial diver, right, they're concerned about liability not just to the individual diver, but to the company, to the municipality for a military diver, or the country, or for national security purposes. For those purposes, you want a very proscriptive standard where you're excluding people that have certain conditions that may put them at risk, and that risk would be translated into the risk into the community, municipality, or things like national security. And I just want to share with you one thing. I intended to take this out on public safety divers. There is no nationally accepted standard for fitness to dive for public safety divers. So we should actually have question mark in that area. So having said that, we're all familiar with the Recreational Scuba Training Council form that we would fill out. And this form has a series of 35 or 40 questions with yes, no boxes. And as long as you check no to every box and you presented that to your dive instructor at the dive shop, and you signed it and you attested that I'm signing this truthfully, you would be permitted to dive without need to seek medical attention or medical clearance to dive for medical fitness purposes. That is the old form. So I want to go over the current World Recreational Scuba Training Councils as adopted by all national, international agencies. And it comes in 3 parts. There's a dive medical participant questionnaire. There's a dive medical physician's evaluation form. And then there's a diving medicine guidance to the physician. So you're probably aware that your primary care physician probably doesn't know much about diving for the most part, yet you're going to them, or you're going to the urgent care center hoping that they're going to determine that you're medically fit. So I want to give you some assurance, not reassurance, but assurance that in medical school in the United States, they don't give any classes in hyperbaric or diving medicine or diving fitness. During residencies in internal medicine and family practice, OBGYN and pediatrics, there are no special electives in diving medicine and hyperbaric medicine and medical fitness in diving. And now I'm a board certified family practice doctor, and you come to me as a diver and you say, hey doc, I've checked off yes to these boxes. Now you have to determine if I'm medically fit. So I'll show you what information you need to know and how you can help your physician help you make the right decisions for your medical fitness evaluation. So the first part of this evaluation is the participant questionnaire. And I'm going to go over it in some detail because I think it's important. So page 1, you're going to fill out the first 10 questions here, and it'll be a very basic screening test. And if it's, I have any lung or breathing or heart problems, so very general overview of your heart and lung status. Or have you been diagnosed with COVID-19? See, updated with the up-to-date information. Are you over the age of 45? Why do we pick 45? Well, we told you that as you age, your risk factors start going up. So we want to be extra careful as we get older, right? To identify patients that may be at risk. I struggle to perform moderate exercise. Now that was never asked on the previous forms. And you know that you need a certain degree of physical fitness to swim, to go off after your dive. If you're 60 yards away from the dive platform off your boat and you have full equipment and the winds are picking up and there's 2 foot of chop, are you physically fit to get back to the boat in a safe manner? Air consumption, all those sort of things. Do you have any problems with ears, eyes, or nasal passages? Have you had any recent surgery? Have you lost consciousness or had migraine, seizure, stroke, or head injury? Are you undergoing active treatment for panic attack, anxiety disorders, drug and alcohol issues? Have you had any back hernia or diabetes? Have you had any stomach or intestine problems? So if the answer is no to all of these, then you simply can sign the document and you don't necessarily need to be seen by a physician. But there's a second part to this. Oh, and by the way, let's look at this signature part. Participant statement. I have answered all questions honestly and understand that I accept responsibility for any consequence resulting from any questions I have answered. So let me tell you, when I got my training for my dry suit, right? We had our classrooms, we had the pool sessions, and I was out at Dutch Springs. Now, I had another student in my class. He was my buddy for the purposes of this certification. And the very first class, when we filled out the RSTC form, he had checked boxes yes to about 6 different things. And then the instructor said, well, hold on, you've checked yes to these things, so you can't come into class. You're gonna have to go to a physician and be cleared. And he said, oh, I meant to check no. So he got another application, he threw that one out, he checked no to everything. Again, and he signed it that he was honest about this. Now we're at Dutch Springs, it was May, but it was probably about 90, 95 degrees. We're fully covered in our dry suit and we had to walk probably 1/8 of a mile with our gear to get into the dive area. By the time we got to the shoreline at Dutch Springs, he was pale, he was sweating, he was hyperventilating, and he was short of breath. I'm assuming that when he actually checked no, he was probably truthful initially, where he had multiple medical issues that potentially could have contributed to a significant issue on my watch, because I would have been in the water with this guy and now I'm going to have to rescue him and putting me at risk. So let's look at the next page to this, which is a more detailed questionnaire. And it then goes into the details related to specifics of different disease entities that can potentially put you at risk. So chest surgery, heart surgery, asthma, cigarette smoke, high cholesterol, blood pressure, diabetes, cardiac disease, family history of sudden death. All these are real risk factors for heart disease. So much more specific. And if you were to check yes to these boxes, it then requires you to go to a physician for a medical evaluation. Now, this is not intended to scare you from being truthful. This is a good screening test to determine if you have any risk factors which would make you a statistic down the road. So we want to prevent that from happening. So now that you've gone to your physician, what does the physician need to do and understand? Well, first off, they can determine that your conditions are acceptable, that there's no risk for issues and you're fit to dive, and then you will have either you're approved and you find no conditions that are incompatible with recreational scuba diving or free diving, because this is now recreational scuba diving and free diving, or you're not approved. And they have a signature and a date, time, and a stamp. The third part of this is the diving medical guidance to physicians. Now, they've always had this guidance, even in the old recreational forms, but this has been updated. And what they've done is they've looked at various conditions, like anything in the head and neck, like sinus infections, polyps of the sinuses, glaucoma. So anything in the eyes, head, and neck will be in one section. The next section will be cardiac. The next section will be pulmonary. And they'll look at certain conditions. And then what they do is they take these conditions and then they determine if those conditions can present a severe risk, a relative risk, or a temporary risk. So what is a severe risk? I checked off yes, cardiac. I go to my physician and I had a heart attack 2 months ago. And every time I walk, I become short of breath and gets a little chest pain 2 months after my heart attack. That will be considered a severe risk. And a severe risk suggests that this would be a substantial elevation in risk of injury compared to the general population. And if you are determined to have a severe risk at that time, it's probably not advisable to dive. And the physician should say not fit to dive at this moment. A relative risk would be something like high blood pressure or diabetes or a back injury. What is that relative risk? If I have no cardiac risk factors, no hypertension, then my risk for a diving fatality due to cardiac disease is low. But if I have hypertension, even if I'm on blood pressure medications, my blood pressure is controlled, so my risk is relative. It's lower than if my blood pressure was not in control, but it's still relatively higher than general population that doesn't have the diagnosis of hypertension. So you can have a relative risk and you can dive. You could have had that heart attack 6 months ago, and during this 6-month interval, you've had cardiac rehab, you've had a stress test that's normal, you have a normal echocardiogram, and you're in an exercise program, and you're running 3 miles a day and swimming, 60 laps in the pool 5 days a week. That now becomes a relative risk because your physician has determined that you've lowered your risk to a relative. It's higher than general population. It's not zero, but it's not severe risk anymore. And then a temporary risk would be an example of, I have a pneumonia, I've got COVID-19, so I can't dive right now. So I've got to treat that, get through that process. Pregnancy is another temporary condition or temporary risk. But once I get through that hurdle and get back to my physically fit, medically fit condition, I can go back and resume diving. So other things that have changed on the heart system, and I'm not going to point fingers, I only see a couple of videos, but another topic I talk about is the aging diver, and all of us can raise our hand and say, yep, I'm one of them. We're all getting older. And as we get older, things like hypertension, diabetes, weight gain, et cetera, can affect the cardiovascular system. And the previous recommendations in the cardiovascular system, if you had a cardiac issue, were to get something called a stress test. You'd go on a treadmill and you would run on it and they'd measure your heart rate and blood pressure and they'd come up with a score. And that score was called the metabolic equivalent task. And that kind of generated a number that if you were able to generate a certain number, it would suggest that you would probably be able to successfully get out of a jam under adverse conditions. So, and I'll give you the example on these slides here. So we go on a treadmill and we run for a certain period of time, and it generates a number called metabolic equivalent task. And these metabolic equivalent tasks are equivalent to the amount of physical activity or intensity of work that I can perform. So we know that if I'm in 40 feet of warm water off Isla Morada without current and great visibility in 76 degrees warm temperature, right? And I'm floating like a jellyfish, I'm not generating any metabolic equivalent tasks, right? My METs would be about probably 1 or 2. If I was taking a brisk walk, my METs would be 3 to 6 METs. If I was running a 10-minute mile, I'd be generating about 10 METs. And if I was running a 7.5-minute mile, I'd be generating about 13 METs. So in the previous documents for Recreational Scuba Training Council under cardiac, it was recommended that a diver who needs a stress test should generate 12 to 13 METs for a doctor to clear them to be determined to be fit to dive. So doing 12 to 13 METs is a really high number, and many recreational divers would never meet that mark. So they may not have any heart disease, but they're just not physically fit. Now, I just did a stress test. I did 13 METs, but I did it intentionally because I want to make sure I'm maintaining, I'm planning to do some scientific diving. So I need to, have the criteria that I need to meet the mark for scientific diving. The new recommendations for stress testing is 6 METs, 6 METs. So what is 6 METs equivalent to? According to this chart, 6 METs is fast cycling, aerobics, some fast swimming, heavy shoveling or digging, walking, climbing briskly up a hill, but it's not swimming or running a 7.5-minute mile. So what does that mean? It means that we can allow you to dive, but it is very thoughtful in the way they describe the stress test here. And what they say is that even though you only require 6 METs on the last paragraph under cardiovascular, this is the minimum requirement. It doesn't say that you are physically fit to dive. So the physical fitness to dive is not determined by a doctor in the office. It's determined by your dive instructor. So for example, if your instructor sees that you can barely swim a lap in the pool, they may be uncomfortable allowing you to go in high currents and strong winds. and may recommend a different kind of diving profile, for example. So as we look then at cardiac, we can look at pulmonary, and they have, severe relative risks, and they give instructions to the physician as to what would be acceptable. Now, realizing that primary care physicians still may not be comfortable in clearing you even with this document, there's also a reference list that will give them phone numbers to call to speak to referral physicians through Divers Alert Network, or for certified dive medicine physicians through the Undersea and Hyperbaric Medicine Society that have special training in dive medicine. Okay, so the current Recreational Scuba Training Council further gives recommendations. These are recommendations, not absolute laws, as far as how often a recreational scuba diver should have a physical fitness exam, a medical exam for medical fitness to dive. And certainly for pre-participation, we need to get that done. And certainly on an annual basis, even if you're healthy, you probably should take a look at that list and say, did I develop a new condition that may put me at risk? And if I did, I may want to seek medical evaluation. If I have 2 more risk factors, so hypertension and maybe obesity, right? And I'm 35, 40 years old, I probably would want to have an exam every 5 years or so and have the physician complete my dive medical physical evaluation. Again, these are recommendations or guidelines. This isn't absolute, you must do it. But divers have always asked, how often should I get an exam? These are the recommendations from the international body of diving physicians, physiologists, and divers. If I'm greater than 45 years of age, I probably should have an exam every 5 years. And if I'm greater than 65 years of age, I probably should have an exam every year, or if I have pre-existing heart or lung disease, on an annual basis. And that will be a comprehensive evaluation, specifically evaluating for diving medical fitness with these new criteria. And this is another way to look at it. And all this documentation are all available online, either through Divers Alert Network or the Undersea and Hyperbaric Medicine Society. They also have the logo shared with the various training agencies. So your training agency should have these forms. Okay, so that's kind of the overview of the current state of Recreational Scuba Training Council guidelines for recreational scuba divers and free divers. But now we're diving in the era of COVID-19. And there's a lot of information that we have today that we didn't have even a month ago or 6 months ago. So what I'd like to do is share with you sort of the progression of knowledge and how it has affected us in the diving community, and then what the current understanding is, and what are the current recommendation guidelines to you or your colleagues, your fellow divers, should you have COVID-19, what you need to do to get back in the water. So in April of 2020, so COVID was first described in January, February, March, April. So after 4 months, a pulmonary critical care physician, Dr. Hartig, a German physician, were treating divers in the intensive care unit. They were all on ventilators. They were all put on breathing tubes. They were all critically ill with COVID-19. They were all ultimately discharged, and they had the question that you and I would have if we have a medical illness: when can I go back diving, right? Which is what we're going to want to do if we're a diver. And he found that in each of these 6 divers, even after discharge, they all had significant deficiencies of persistent oxygen deficits. They had abnormalities that persisted on their CAT scan, so a sort of a formal X-ray of the lungs. They had abnormalities in their pulmonary function, so they blew into a machine which basically measures the volumes of the lungs, capacity of the lungs, and the ventilation of the lungs, if you will. And as a result, he wrote an article in German, in a German medical magazine. And his advice was, in German, that the divers should never dive after they have COVID-19. And that German article was translated into English, and there were a couple of words that were missing. What he really said was, these 6 divers should never dive again because of these abnormalities. But it was misinterpreted because of the language that divers shouldn't dive after they have COVID-19. So this is an example of a CAT scan. And I wanted to let you know that these arrows, so the CAT scans don't have arrows in them. Your lungs don't have arrows. The arrows are here to illustrate that these sort of white little patchy things, those are the remnants of pneumonia from COVID-19. And these, so if you have these patchy, they're called infiltrates throughout the lungs, when you have these patchy infiltrates that don't resolve, that could potentially increase your risk for things like pulmonary barotrauma, which would be a bad thing. And these are the reasons why these patients had persistent oxygen, low oxygen levels. And if we see someone who has really bad disease, on the bottom here, far right, in my laser pointer, you can see that it's almost like fluid filled, and most of the lung field is filled with this inflammation of COVID-19. So I'm not oxygenating, I'm not breathing well. My oxygen consumption, if I was diving, I'm not even sure I'd be able to do that. I'm probably going to be on supplemental oxygen when I go home from the hospital. So pretty significant stuff. So that was April of 2020. The very next month, or within that month, the Belgian Society of Diving and Hyperbaric Medicine wrote an overview of recommendations for divers who have COVID-19. And so they looked at things like the risk of infection, the risk of pulmonary barotrauma, the risk of cardiac events, the risk for pulmonary oxygen toxicity, and the risk of decompression illness were all relatively unknown for patients that had COVID-19. So their recommendations were that we would recommend that you will need to be out of the water for a significant period of time and have an individualized medical evaluation. And then when you return to diving, that you should dive well within the no decompression limits because of the risk of developing some of these complications after the fact. And again, not a lot was known at that time. So further information that sort of kept divers out of the water. And in the British Subaquatic Club and the recommendations in the United Kingdom, they weren't allowing divers in the water at this time because of these recommendations or lack of knowledge. So the question here is, what do I do if I'm diagnosed with COVID-19? And I'm sure, and I don't need to pry into anyone's medical history, but a number of you have probably had COVID-19 during this past year. And so the view of discussion then is, the key is you don't want to dive if you're symptomatic. Your concern, of course, is spreading that to other patients or other divers. But the issue is that every COVID-19 patient will have different symptoms. It'll affect different organ systems. It could affect the heart, it could affect the lung, it could affect the nervous system, it could affect the muscles. You could have cognitive impairment. It could affect the skin. It could affect vision. It could affect smell and taste, okay? Everyone will have different symptoms, and it can impact your ability to tolerate exercise. So the first pass is, if you have had COVID, before you go back in the water, you should be evaluated by a physician who hopefully has knowledge in dive medicine and works with you to decide what you need to do before it would potentially be safe or too risky to go back in the water and when you could do that. So it really depends on your symptoms. Are you the patient on the left who is in an intensive care unit on a cardiac machine called an ECMO machine because you have 7-system septic syndrome, you have acute renal failure, acute heart failure, you have cerebral edema, you have seizures, you have persistent hypoxia or lack of oxygen, you're critically ill on a ventilator with ventilatory failure in an intensive care unit where it required them to put a chest tube in because you had a collapsed lung with profound pneumonia and cardiopulmonary disease, and you were in the intensive care unit for 3 months, and you were in the hospital for 45 additional days before you were discharged to home? Or are you the diver on the right who simply goes to the doctor's office or urgent care center with a cough, achiness, and mild headache? 2 different types of illness, right? And clearly going to be 2 different types of recommendations and guidelines, but it's going to be a very individualized approach to each of these individuals. Am I medically fit to dive with COVID-19? So the answer is that the medical community doesn't have sufficient data to make a generalized broad recommendation to the entire community. This is what you all need to do. It has to be a very individualized discussion with a physician who's understanding of what your work requirements are as a diver. So if I'm a recreational diver, if I'm a cave-in diver, how do I get back to my normal activity based on the illness and disease that I had? So the medical evaluation is specific to the degree of medical illness and the degree of recovery. Some of you may be familiar with a technical rebreather diver. His name is Dick Ebersol, and he is a cardiologist of all things in Florida. He's also a dive instructor, and he's a phenomenal guy, and he's probably one of the leading authorities in cardiac fitness in diving. And he speaks internationally and nationally on all aspects of diving medicine and cardiac diving fitness. So a world expert. He was in his office in Florida, and a patient came in, an old guy, and the old guy was short of breath. And this is during COVID-19. They both had face masks on. They both had N95 masks on. And he examined his patient who was short of breath. He used his stethoscope. He listened to the lungs. And he determined that this old man was so short of breath, his oxygen level was low. He was in congestive heart failure. He called the ambulance. They transported him down the street to the hospital. When he gets to the hospital, it is determined that the patient actually has COVID-19 and not congestive heart failure. The very next day, Dr. Ebersol starts having fevers, chills, and a cough. And guess what? Dr. Ebersol now has COVID-19. His symptoms were, we would consider mild symptoms of an achiness, flu-like illness, cough, congestion, weakness, and it lasted about 7 to 10 days. He isolated himself, and he didn't see patients further. And after about 2 weeks, he was feeling much better. Now he wants to dive. This is a guy that dives all the time, travels all over the world. And the way he got back into diving was he did it gradually. Now he has access to all the toys and the tools in his office, pulmonary function studies, X-ray, EKG machines, echocardiogram, but he didn't treat himself. He went to a physician that he knows, that also knows what he needs to do as a diver. And he was assured with pulmonary function testing that his lung function was normal, that his X-ray didn't have any persistent abnormalities, and that his heart was not damaged from the COVID-19. And then he started going on his rowing machine. Normally he would row 45 minutes a day, 6 days a week. He went on it the first day after 3 weeks of not being active, and he rowed for 15 minutes, and the next day 20 minutes, and the next day 30 minutes. And after a week, he was back to 45 minutes, doing that daily, 7 days a week. And then he started taking long walks and running. And then 2 weeks later, he did a shore dive to 15 feet with his wife, who's also his dive buddy and the wife. And then he did another shore dive to 20 feet and 30 feet on compressed air. And then he said, I'm doing pretty good. I don't have any exertional shortness of breath. I have no pain, no symptoms. My oxygen level's good. I feel great. My exercise capacity is back to normal. And then he slowly but gradually went back to his normal diving activity. So that's sort of the model for each and every one of us. We'll have to define what degree of illness I have, share that with my physician, and then look towards getting back to a normal exercise capacity, and realizing some of us who are those patients on the far left in the intensive care unit who have significant cardiopulmonary issues, it may take a long time before they get to dive, and it may be a situation because it's unknown whether they can ever dive again. But I think that will be less common. So what are the latent effects or delayed effects of COVID-19? So if it affects my heart, I can have a heart inflammation. I can have the lower chambers of the heart are called the ventricles. I could have ventricular dysfunction, which means I can have a life-threatening rhythm disturbance. Again, that's a bad thing to have, and I need to determine if I had any effect on my heart. From the respiratory status, my pulmonary function can be persistently abnormal, and I may need some form of pulmonary rehab to get me back to my baseline. I could have issues on my kidneys. I could have acute kidney injury. It could affect my skin, my hair, and neurologically, I could have significant cognitive issues, memory impairment, and sleep dysregulation and panic attacks. All anew, all related to COVID-19. And I could also be left with issues related to depression, anxiety, and changes in mood that could affect my ability to function in a normal capacity if I'm diving. There's something called long hauler syndrome, and these are patients that got COVID-19 and seem to recover. It took them a long time to recover, but they're left with residual symptoms, persistent symptoms like coughing, ongoing symptoms of debilitating fatigue, body aches, joint pain, shortness of breath, loss of taste and smell, difficulty in sleeping, headache, and they call it brain fog. Again, having any of these symptoms, if I just had loss of taste with no other issue, I'm good to dive, right? If I'm having challenges with difficulty in sleeping, but I'm well rested, I'm diving, everything else being equal, and with a dive buddy who is aware of some of my issues, I'm probably good to go. But if I'm having debilitating fatigue, coughing, shortness of breath, right, I need to address those issues way before I even consider going back in the water. So ultimately, when we're talking about COVID-19, there's a complex number of issues related to fitness to dive in the evaluation. We have to look at the degree of illness the individual diver had, what their persistent symptoms are, and what systems were affected, whether it's heart, lung, brain, pulmonary, etc. And then on an individual basis, appropriate testing. And I can't give anyone a recommendation that if you go to the doctor with COVID-19, before you get back in the water, you should have this test, that test, and this test, because it needs to be individualized based on what your symptoms were, what your symptoms are, and what your physical findings are with that physician. So that would be an important thing to know. So again, it's an individualized basis. So what's a diver to do? So I hate to sound like a cliche broken record, but you got to follow the CDC guidelines. This isn't a political issue. This is a life-saving issue. We're trying to get our businesses back on, get our divers in the water, divers in a shop, divers on a boat, divers to our, vendors. We want to be successful, but we've got to do it smartly. Social distancing is something that's going to be with us for some time. Face masks are key to helping decrease the spread of COVID-19, and meticulous hand washing, having hand sanitizer, soap and water, And then certainly the purpose of tonight's discussion is not to give you your various training agency recommendations based on cleaning equipment and what training modifications you need to make, whether it makes sense or not, whether it's a good idea or not. But you need to follow those agency guidelines to the T, because that is the best that we can do, is provide a consensus based on our best input from the experts. Vaccination is absolutely important. You know, your criteria based on your age, when you get it, whether you get the 1 shot or the 2 shot, whether there's a delay in getting it. The answer is that COVID-19 vaccination will be helpful. And where we're concerned about these variants, whether the vaccine will work, if it's your turn to get the vaccine, the only thing I can say is please get it. That will be very helpful to helping lower the incidence overall throughout the United States. But many of us travel. We travel around the world, right? And although we complain that we haven't got our vaccines, that it's corrupt and this one's doing that, there are many countries in which they have 0 vaccines because they don't have the wealth that the United States and other countries have. So when you're going to travel, even when you're fully vaccinated, please do your homework on where you're going to and what those rules are of engagement and what percentage of patients are vaccinated and what kind of hospitals are there should you succumb to illness. So ultimately, when you're having your medical assessment, you're having that conversation with your physician, and ultimately it's confirming that you have a full recovery. And it could be a simple thing. If I just had joint pain and a fever, and I go to the doctor's office and he listens to my lungs, he checks my oxygen level, and I'm telling him that I'm running 2 miles a day, swimming 60 laps every other day, and I'm not short of breath with difficulty in breathing, then I'm probably going to be cleared just based on that. I'm back to my normal exercise capacity. But if I'm having some shortness of breath or some exertional shortness of breath, whereas normally I could walk up a flight of stairs, but now in about 10 steps, I become short of breath, I may need to get a chest x-ray, I may need to get a pulmonary function study. And because I'm concerned about cardiac implications, and I'm also not 21 and have high blood pressure and diabetes, it may be reasonable to see what my EKG is and possibly even an echocardiogram, because we know that the COVID-19 can affect the heart with inflammation. And then you need to be able to safely perform unrestricted vigorous activity like you normally would prior to going in the water. And then once you get in the water, you do it smartly. Start in the pool, shore dives, slightly deeper dives, and then getting back to your normal activity. Optimally, it would be great to be able to be seen by a board certified dive medicine physician to help you in some of these, challenging cases. But in reality, there are not a lot of me around. So you're left with going to your family doctor or cardiologist that may or may not have the expertise in dive medicine, but is probably pretty good at evaluating you for your post-COVID-19, your hypertension, your diabetes. And there are guidelines out there that can help them through this diving medicine fitness guideline that is presented to you through the Recreational Scuba Training Council. Okay, this is a plug for Divers Alert Network for their DAN COVID study. Now, I am a DAN referral physician, I'm a DAN instructor, but I'm not a DAN employee. They don't pay me. I've never gotten paid by Divers Alert Network. So this is not a, I'm not influenced by anything except to say that this is an organization that is trying to get data from scuba divers that have had COVID-19. This study is free. It's not going to take a lot of time. You would need to contact them. There's contact information here. You can just look on the DAN website for COVID study, and you can get in touch with Dr. Frauke Tillmans, and she is, getting this study. The eligibility is you have had to had confirmed or suspected COVID-19. You had to have recovered or are still recovering, and you have returned or are planning to return to diving. That's the entry criteria. You fill out some information, It probably takes you 15 or 20 minutes if you're slow, a one-time registration, and there'll be follow-up studies, 9 surveys over a 5-year period. Each survey will be about 5 to 10 minutes. The more information we have down the road, the better off we will be as a diving community when the question is asked, when is it safe for me to return to diving? What are the residual effects? They'll monitor each and every one of you in the study and see, did you actually go back to diving? What's your current diving? It'll be an impressive study when they have a lot of numbers of people. So please invite your friends and family who are divers, spread it out to the diving community to consider enrolling in the DAN COVID-19 study for divers. All right, again, I'm a DAN referral physician, DAN instructor, but I don't work for DAN. When COVID-19 first came out, DAN actually had a number of free webinars that they're YouTube videos now on dive operations with COVID-19, first aid training, and COVID-19, diving after COVID, DAN oxygen units and treating during COVID, and disinfection of scuba equipment. That's all on, you can Google that. It's all on YouTube. All training agencies at this point have a lot of more education. Some of the tech manuals and training agencies have more useful information. There's ongoing educational forums through Divers Network and other organizations to help you navigate the ongoing changes in COVID-19 and diving in the era of COVID-19. So we know that the diving environment is unique and not natural. There are many hazards. It can be disorienting, issues related to visibility, and the gas laws always win, right? Henry's law, Dalton's law, and Boyle's law, you can't beat them, right? There's issues related to gas toxicity and overexpansion. And how that affects your unique physiology, your diving medical fitness, is key to whether you will come home safely or be a statistic. So ultimately, when you're going to your physician for your evaluation, there are 2 parts of responsibility here. The physician is in a unique position. They need to identify and explain the partial or unacceptable risk to you as a diver. Now, it would be great if they understood what those risks are and what the physics are of diving that could relate to your underlying physiology. Again, they have guidelines if they're unaware of that. The diver's responsibility is to identify potential problems, old or new, and bring them forward to that physician. So you don't go to your physician, say, I had COVID-19, and don't forget to tell them that you had chest pain, shortness of breath, that you were blue and cyanotic, that you were actually hospitalized for 2 days. But you don't want him to know that, because if he thinks you're that sick, he's not going to declare you fit to dive. It may mean that he has that information and needs to do further evaluation before he can make the best decision for you. The diver's responsibility during this exam is then to process the information. If I tell you as a dive physician, it's dangerous for you to dive. And I had a situation where I held an elderly, overweight gentleman who's a scuba diver that's had thousands of dives in his lifetime. And he became sick. He had a defibrillator pacemaker placed, and he had something called congestive heart failure. And he had a stress test. And during the stress test, he went into a life-threatening ventricular arrhythmia. His cardiologist told him that you shouldn't dive more than 50 meters. That was his clearance, 50 meters, not 50 feet, right? So he came to me, the patient, and to get my opinion. And I told him, you should never dive again. Having a defibrillator pacemaker with congestive heart failure is a death sentence. It's an absolute contraindication to dive. And I told him that. So he had to process the information, and then he had to make decision making. He had to decide on, now that I have information, I could take the information that Dr. Charash gave me, throw it in the garbage can, and just go with the recommendation of my cardiologist. And in fact, that's what he did. And about a week later, I saw on Facebook he was in Fiji diving. Glad I wasn't in Fiji that week. So in summary then, when we look at and think about diving smart, we have to always be aware of our ability to be fit to dive, and based on a classification to dive and our work requirements, We have to maintain our physical skill, knowledge, physical fitness, nutrition, psychological fitness, and medical fitness. And if at any one moment we feel any one of these components are not adequately addressed, then at that moment we can be temporarily not fit to dive. We could wake up that morning with a headache, nausea, and vomiting, and we can decide this is not a good to dive. Or I have such severe back pain, my physical ability, physical fitness would not allow me to be successful and possibly put me at risk. So we need to address these 6 components every day, every time we go into the water, and ideally before we go into the water. So we need to address medical fitness with long-term goals, with an expectation that the doctor isn't going to say we're never going to dive again, but give us guidelines and recommendations to allow me to become fit to get back in the water. And I'm speaking to the choir because you're all here learning, but we need to continue to educate ourselves, continue to develop more training and knowledge. And I think it's an absolute minimum mandate that every scuba diver has to be CPR certified. There was a dive trip, I wasn't on it, thank goodness. One of the dive clubs, they were on 2 boats, and I won't tell you where or which dive club, and one of the divers at 30 or 40 feet became unconscious and was flailing underwater. He had to be rescued to the surface. He was in full cardiac arrest, and he was dead. Cardiac arrest and died. No one on the boat, including the boat captain, was certified in CPR. They winged it. They saw it on television. Someone took the CPR class many years ago, but that is the worst situation. CPR is a life-saving technique that we should all be comfortable with, and we should all be familiar with, and we should all be CPR certified. And I would also suggest advanced training, whether it's through DAN or EFR or whatever agency, you need the advanced training and use of oxygen, oxygen delivery, neuroassessment. This is really sort of minimum requirements in my estimation. And then as the cliche goes, you want to plan your dive and dive your plan. Now, the last thing I'll share with you is how many people here have seen someone have an arterial gas embolism? You can, anybody? Probably not, because it's pretty uncommon. So what is the most common cause for a pulmonary, acute, arterial gas embolism? What is the most common cause for a diver to get an arterial gas embolism?
Smoking?
Not smoking, no. It's breath holding on ascent, right? You're getting pulmonary barotrauma. And that's why when we do our training and we practice, we rehearse that we aren't going to hold our breath as we ascend. Because when we ascend, Boyle's law is causing the volume of the alveoli, the air in our lungs, to expand, right? When we're decreasing pressure, we're increasing volume. When it increases volume suddenly and we're holding our breath, it snaps like a rubber band and the alveoli rupture, and you have air circulating around that shouldn't be there because it's not contained within the lung tissue. That air goes onto the right heart circulation into the brain, and that's called an arterial gas embolism. So the most common cause is breath holding on ascent, and typically you see arterial gas embolism present usually immediately at surface or within the first 10 minutes. And it's often a severe catastrophic event associated with neurologic, something catastrophic, either neurologic or cardiac. So I'm going to show you a diver who developed arterial gas embolism while diving. So this is the setup.
Every day.
Someone shut the just mute all the mics if you would. So this is in a Navy, in the Royal Dutch Navy submariners. If you're in a submarine and your submarine ditches at 200 feet, for example, and you have no hope of rescue from above, they train scuba divers, the submariners, to get in a special suit. They lock out of the submarine, and at 200 feet underwater, they're going to swim to the surface to escape. As they come to the surface, they train the submariners to exhale continuously or blow bubbles, because they don't want to risk breath holding on ascent. Otherwise, they'll get pulmonary barotrauma and risk an arterial gas embolism. So they put these submariners in a 30-foot swim tub at 30 feet. They'll take their face mask off and have to mentally practice that they're swimming to the surface. Now, normally they will, at depth of 200 feet, will have an ascent rate of 300 feet per minute. That's how fast they shoot up like a rocket. And they wear this suit that has a little bit of air in it. And as they start to ascend, it fills up like a big balloon. So they're highly buoyant. So they shoot up like a rocket and they're exhaling. So this is the Royal Navy diver on the left. This is the instructor on the right. He's going to take his mask off and he's going to simulate swimming to the surface. And while he swims to the surface, he needs to be blowing a steady stream of bubbles. So let's watch the diver on the left go up, the student, hardly blowing any bubbles, right? Hardly blowing any bubbles. Now the instructor above him is going to recognize he's not blowing bubbles and he's going to tap him on the head. See, hardly any bubbles, right? He was breath holding on ascent. Boyle's law states that I'm decreasing pressure, I'm increasing the volume of my alveolus. Now he's blowing bubbles because he was reminded, you've got to exhale. Now watch what happens from above. Now he's blowing those bubbles, steady exhalation of bubbles. You're doing this at almost 350 feet a minute, right? Going really fast. When you get to the surface, now you're going to swim to the exit of the pool. I want you to pay attention to his left and right fin. We'll see an underwater shot of this. He's immediately surfacing. He was breath holding on ascent, which is the most common cause for pulmonary barotrauma and arterial gas embolism. Usually presents with neurologic change. Look at his right fin, left fin, right fin, left fin. And about right now, he can't fin with his right leg. He has a neurologic finding, acute arterial gas embolism from breath holding on ascent. That's pretty impressive. Now you can never say you've never seen anyone with an arterial gas embolism. And this is a stark reminder of how important it is to, and many of us have been out of the water for longer than we'd want because of COVID-19. It's probably a great idea that we gradually get back into getting into a pool, going over our training and rehearsing, getting recertified by our various instructors, being comfortable, reminding ourselves what is the proper technique, what are the things I can do to reduce my risk, have I had a medical evaluation, am I medically fit, am I physically fit? So let me, sorry, one more thing here. Okay, so with that, I want to thank you for your attention. And if it doesn't get too congested, you're welcome to open up your mics and we can have question and answer. Could be about this or any other subject. I don't know if I have much information on anything else, but I'm happy to chat with you.
So David, we actually had a few questions in the chat that I want to address since they got posted up as you were speaking, if that's all right.
Sure, let's do that.
So the first one was from Chrissy asking, when you were talking about the DAN survey results with pre-existing conditions, did it break down by disease like respiratory, CV, neuro, etc.?
Yeah, it did, but the 28% were those who had cardiac. So there were others that had lesser degree of disease, but it was a high preponderance of cardiac disease. So, and it becomes very challenging. How do you make the diagnosis of whether it was a triggering event or primary event? It's based on autopsy, right? A pathologist is examining you in the morgue, essentially, and they determined that this patient had a cardiac event, and they determined that they also had an arterial gas embolism. So what was the fatal issue? Well, he died of the arterial gas embolism, but the triggering event was that the patient went into congestive heart failure, right? Because he had uncontrolled hypertension, or he had, pulmonary edema, and he made a rapid ascent because he was feeling out of sorts, or he had a heart rhythm disturbance. So, they will oftentimes be triggering events, and you don't necessarily just die of a heart attack. You're going to have a heart attack, but as you're having the heart attack, you're panicking, you're running out of air. You can, aspirate and die of drowning. Drowning is another common diagnosis for a fatal outcome. But when they do the autopsy, they also see that you had triple vessel, three vessel disease with an unstable heart. So there was underlying cardiac events that were occurring as well.
That makes sense. Same poster, Chrissy. Is there a plan to review fitness guidelines more frequently going forward? A recent update now, yet will it be reviewed at the 5-year mark or similar?
That I don't know, because I wasn't party to that. I am on the Dive Fitness Committee for UHMS, and so we just sort of get the final outcomes of the surveys. I certainly can ask that question. In June, I'm meeting with the Undersea Hyperbaric Medicine Society. There's actually going to be a forum on diving with COVID-19, and at least 2 of the people that are on this international committee will be there. I certainly can get that information to you then.
Okay, very good. Jason was asking, are all COVID cases treated the same, asymptomatic?
What do you mean treated the same? So if you have COVID-19 and you're not having any symptoms, there is no treatment for it. It's a virus, like any other virus, right? Like the flu, there's not a pill or anything, you're just treating the symptoms. If you're having COVID-19, but you've had cough and fever, some it may be just lack of taste or lack of smell, right? So, for the mild symptoms, there is no real treatment for it. If you have COVID-19 and you're having significant symptoms, they are giving the immune therapy, Regeneron and other similar kind of products that your physician should be referring you to for outpatient treatment. And that tends to decrease the progression of disease if you give it too early. So what typically happens after you get COVID-19, if you really become sick, is after about day 14 or so, there's something called an inflammatory cascade. It's these cells that cause the systemic issues related to cardiac and pulmonary dysfunction, and you really get sick. And if you can get this immune therapy prior to that, that's often enough that prevents it. You saw that in the news when President Trump went to Walter Reed and he got his cocktail, right? If you get that cocktail, whatever that cocktail is, it could be steroids, it could be immune therapy, that if given early can be preventable. You wouldn't give it to someone that just has COVID-19 with no symptoms.
Sure, makes sense. Ed was asking, what are the recommendations, procedures for patients who are hospitalized for other viral respiratory illnesses, i.e. severe flu?
Yeah, I mean, it would be no different. If you have severe medical illness and you want to dive, or if you had congestive heart failure and you want to go dive, you probably should be going to your family physician and saying, hey, look, I'm going to be diving again. I was pretty sick. I was laid up. I was in the hospital for 4 days. My oxygen level was low. I have a 20-pound weight loss. I'm sort of getting back, not at full strength. I want to get back to my normal activity. And it sort of depends what your age is. If you have heart disease, this physician who understands what kind of diving you're doing. If you're a recreational diver just diving in the shoreline and never going deep, may not need the same degree of fitness as someone who is a technical diver or a wreck diver, right? If you're going to do scallop diving in Gloucester, right, in cold waters, you probably need to be somewhat physically fit.
Sure. Jeff was asking, I think when you were talking about and showing the CT scan, it's easy for us to imagine how all of those blips, voids, cysts in the lungs could lower O2 absorption and decrease cardiovascular performance. But they also looked a lot like voids for air to collect in to this ignorant layperson. Even if one could run a marathon without breaking a sweat afterward, do their presence increase the risk of air embolism?
The answer is it increases the risk for pulmonary barotrauma, which can cause air embolism. That's correct. So that's why, and what's not known is there are a number of patients that were asymptomatic and they did chest x-rays on them, and they were found to have the abnormalities on the chest x-ray. And these were patients that didn't have low oxygen levels that weren't hospitalized. So it really is an individualized situation. There are other people that have died of, it's called a pulmonary embolism, separate of, it's not an arterial gas embolism, but it's a blood clotting disorder. And you can get the blood clot and go to the lung. And we've had a couple of these, in the news, some young, healthy kids who were pretty sick, weren't hospitalized. They were improving symptomatically. They were great. And a week later, they had sudden death, and they were found to have a pulmonary embolism because of blood clots, because of the profound illness they had. So, I can't give you a generalized picture. If you're not having any lung complaints and your lungs are clear and your symptoms were mild, I don't know I would necessarily get a chest x-ray on that individual.
Very good. Another question from John. How many divers actually get an autopsy versus the MD simply saying they drowned?
The reports that Dan gets are autopsy results. So, okay. I can't tell you, there are plenty of divers that just die and they can surmise it, but in that database, it's those who had autopsies.
Makes sense. Spyro was asking if you've had a positive case of COVID-19, but you've had no symptoms whatsoever, would you still suggest seeing a doctor before diving?
I would, and here's the deal. If you're a marathoner and you're running 26 miles every week, and you have a pulse oximeter at home and you're checking your pulse ox. I mean, I have on my smartwatch, I know what my pulse ox is at all times, what my heart rate is. I may not go to the doctor. It may not be wise of me not to go to the doctor, but I probably would say that. But if I'm the dive physician and a Dan referral physician, I'm probably going to tell you it would make sense you'd want to consider going to your doctor. And if he listens to your lungs and say you're good, then you've done your due diligence.
Sure, makes sense. Eric asked a question that I think I might be able to field. Are the risks of COVID transmission understood during an emergency in water air sharing? So at least from our part, the agencies have disseminated information down through COVID-19 that we've changed process and procedures, that sharing the primary as it stands right now is kind of put to the side, and protocols have been implemented where air sharing is now on particular second stages. So at least within the SSI system, when you're doing pre-dive checks, you test your primary and then you test your dive team's alternate, and then they test their primary and they test your alternate. And then you guys stay together during your training, and only one mouth hits that second stage mouthpiece until it's sanitized before it can go in someone else's mouth. So it has been considered, and I believe most of the training agencies are on that same line. David, do you know that to be different or the same?
No, that is a recommendation. And, on the chatter on the various blog posts are like, oh, that's not acceptable, we shouldn't do this. The reality is that's what you should be doing. It makes sense.
Yeah, I agree. I mean, it's not the perfect method, but it's best, any port in a storm, right? It's the best of a current situation. Did anybody else have any other questions? That's the last I have from the chat.
I do. I have a few.
Yeah, go ahead, Alan.
I'm Alan Wallach, and I have a couple of questions. I was taking some notes as you were talking. Thank you very much. This is excellent. I've learned a lot. First question has to do with the form you talked about. Can you hear me?
Yeah, I'm listening.
Yeah, we can hear you.
Okay. Is there a timing on the form? First of all, I'm not one of your young divers. I'm 75 years old. Right. I bike ride, I ski, and I dive. So I'm alive. Right. But I do go yearly visit. And when you fill out that form, being this alive this long, a lot has happened to me. And when it says you're having an operation here or this there, is there a time frame on that form? Is it within 5 years, 10 years, your lifetime? What is it that I have to fill out? Is it a time frame?
Well, so the answer is that historically, if you were a recreational scuba diver, that's when you filled out the form. And if it was signed off when you were 25 years old and you never got any further certifications and you never went on a international trip, you would never have to fill that form out again, right? That's
okay.
Typical.
So if it was filled out like 7 years ago or 6 years ago and I was okay, I wouldn't have to fill it out again if nothing happened?
Well, the answer is this, that the guidelines and recommendation have changed. It includes things like COVID-19 and issues related to cardiac disease. So, and they're also recommending that the current recommendations, not mandates, are that if you're 68 and older, you should have an annual diving medical evaluation.
Okay, that's my next question.
Right.
Since I'm 68 years and older, my next question is this. I do have a yearly medical, and because many years ago I had a double bypass, I also have a cardiac every year, a stress test, and a nuclear stress test to make sure that there's no damage in my heart, and I pass them all totally every year.
Yeah, so the answer is that when you have your annual physical with your primary care doctor, with your stress test in hand, you can say, hey, doc, I'd like you to review this form and fill it out. And this way, you know, if you travel, if you're going to go to Belize, whenever we are able to travel again, you know, they may ask you to fill that form out again.
Okay.
Right? And you're going to say, oh, well, I've had all these conditions. The answer is yes, yes, yes. Well, they're not going to let you dive. But now you're going to show up there with a recent form that was filled out this year with a copy of your stress test echocardiogram, and even a letter from your cardiologist that says you're cardiac fit. Now you're going to be relative risk, right? You're not zero risk despite being healthy and young and spry and doing all these things. It's a relative risk
because of my age,
because of your age and your past disease. So
okay.
it's relative, but relative control, not severe risk.
So the next question is, when I was talking to my doctors about can I dive, because I always ask every time I go, is there any issues? They really don't know. Why my cardiologist went on the website, they'll say, let me know, he's researching stuff. Where can I tell him to look to make some of that determination?
That dive medical fitness form will be a good part to start. So
that's a good part to start?
Yeah. So
research on that?
Download that, review it yourself, look at the cardiac and see what it recommends, and you can email it or fax it to your cardiologist and say, you know, this is the current new recommendations, and that if you're not really clear, they'll have guidelines of numbers to call or people to call that are dive medicine physicians that can give him guidance.
Okay. I think you've answered those questions. So I can get that dive medical fitness form.
Yeah, off the Undersea Hyperbaric Medicine Society website, off the DAN website, and I'm
website. Okay.
Patty and SSI and MOUSD and Mickey Mouse. They have all the forms now, right?
All right, because I just took my physical, and I'm on my second shot next week for my COVID. So I'm pretty much
right.
But my next dive trip will be like 6 weeks from now. So
yeah, but I mean, you can, now that you had the physical, you can give them a form. Please fill it out.
Okay,
right?
good enough.
Have it because
Thank you.
If you're going to travel, they're going to want an updated form, and if you
Yeah,
check and it's not signed, you know, you're going to be a little disappointed.
All right, that's good advice. Thank you.
Yeah. Any
Brilliant.
other questions?
I think most of them got cleared up in the chat, so we're getting close to 8:30. I know you've had 2 overnight shifts, David. So I think we're probably in a good spot to wrap it up. We've taken a good amount of your time. So I just want to thank everybody for joining us this evening. And thank you to Dr. David Charash for generously donating his time for this very informational talk for us this evening. If anybody has any questions, obviously you can see Dr. David Charash's email, dmcdivemed@gmail.com. And then his website, divemedicine and hyperbaric-consultants.com. I will be, I have recorded this, and so I will be finalizing the recording. Once it finishes rendering, I will get this posted up to YouTube and Facebook tomorrow, and we'll share in the usual ECD channels. But if that's good, thank you very much, everybody, and very appreciate your night.
Have a great night. Thank you very much, Nick. Thank you.
Thanks, guys. Thanks for having us.
Thank you.